Hello, I'm Donald McCauley, and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Denmark, and I'm talking to John Brodersen. John, you've had a very distinguished academic career, but let's bring you back to the beginning. What got you into medicine?
At gymnasium, which you do in Denmark when you are between 17 and 19 or 18 and 20, I was really good in maths and physics, and all my teachers thought that I should be an engineer. And I have always loved to talk to people and connect to people and be doing something about relations. I signed up for the engineer school here in Copenhagen, but I regretted after working 1 or 2 months in my summer holiday. So I gave up the thought, and then I was looking around and talking to a lot of people. And then one day, one of my good friends, she said, John, you have to do the combination of math and psychology, so do medicine. And then I started at the medical school here in Copenhagen, at the University of Copenhagen, and I couldn't really fit into the other students because they were, most of them were children or grandchildren of other physicians or doctors, and I have no academics in my family. So it was really difficult for me, but then after a year, I started doing some shifts as nurse or nurse assistant. And then I just loved being with the patients. And then, yeah, then during those, it took me 8.5 years to do the 6 years because I did a lot of traveling and had sabbaticals and took a relaxed time. Then I finished medical school and was uncertain about what to do because I loved most of the themes that we were presented to. And then I started working at the hospitals, and I thought that this is not human. This is not, this is so disease oriented. And then I had in my internship, I had half a year of general practice, and then I fell in love with general practice. And after trying pediatrics and internal medicine, I decided to go as a GP. And when I did training as a GP, it was 3.5 years, and we had a course in research, and we were asked to do a proposal, and I did a proposal on the consequences of having a false positive result, because I had seen some people having false positive results, and I was shocked by all these emotional reactions to an abnormal test. And that start and that proposal ended up with a grant, and I got 3 months of preparing a proposal, and then I was in a year. I was matriculated as a PhD student, and then I did my PhD on psychosocial consequences of screening mammography. And during my PhD, I started reading some literature around overdiagnosis. I have never heard about overdiagnosis. That was in 2001, 2002. And then I was asked by the weekly Danish journal for physicians to do a kind of review article about the harms of screening mammography. So, and then I looked into all the literature around all the unintended harms of screening mammography and started reading about overdiagnosis. And that had that consequence that after my PhD, I have actually been doing a lot of research in overdiagnosis and is now strongly involved in research about overdiagnosis.
You talk about unintended things, but behind your head are the covers of the BMJ, which reflect some of your most dynamic work. Tell us about that work.
We did a paper around 2010, which ended on the front page of BMJ, about what are women told when they're invited to screen mammography. because we had looked at all the different invitations around the world, and we knew about the best available evidence on benefits and harms. And then we could look at it, how it was communicated. And it was really fraught, and it was really biased. It was overemphasizing all the benefits, and it was underemphasizing or ignoring the harms. So actually, women in our countries didn't have the option to do a freely evidence-based informed choice. So I've done several studies on information leaflets, but I've also gone further and looked at how are administrators and authorities that are inviting people, how are they framing their invitations? And we have found several framing effects. Then they are all trying to improve or increase the numbers of people participating, but they're actually manipulating with the women because they can't see through the framing effects. So it's not about nudging, because the definition of nudging is that you should be able to see that somebody is doing something with you, like at men's toilet, we can see this fly when we pee, and then we have to hit the fly, not to make it more clean when we pee. So that we can easily see that we are nudged, but when women are receiving those information leaflets, they can actually not see that framing effects are used. So they're, in our definition, manipulated. And we have actually then also tried to do an information leaflet for cervical cancer screening that is evidence-based with all the best available tools, with no framing effects and absolute numbers and same denominator for benefits and harms. But the problem is that cognitive dissonance appears. So if you have a very strong assumption, or you are told by authorities or healthcare systems or your GP that screening is a really fantastic tool to prevent cancer, then you believe in that. And when you're then meeting facts that goes against your thoughts or your beliefs, then you can't perceive it. So we call it a perception gap, and we use the psychological theory called cognitive dissonance, that no matter how good the information leaflet is, it doesn't help because people can't perceive it, because it talks against their strong pre-assumptions. So that's one of the front pages. The lower one is about communicating. How should we communicate about overdiagnosis? Because it's really a ethical dilemma, and we call it the tightrope, this one. Because when you and I as a GP will see a male patient that we think is overdiagnosed with prostate cancer, this male patient will probably not have any benefits from our communication saying you are overdiagnosed. On the other hand, if males comes to us and want the PSA test, they should certainly be told about the harm of overdiagnosis and the risk of overdiagnosis, and how many are overdiagnosed, and what are the balance between benefits and harms. So sometimes we really have the ethical obligation to communicate overdiagnosis. On the other hand, we shouldn't harm people more than they are already harmed. So it's a really fine balance, communicating overdiagnosis.
It's very interesting, this business of how you communicate that message, because we've always been fed the message in terms of cancer diagnosis, for example, that the sooner the better. But that's not something you would agree with.
First of all, cancer is not cancer. Cancer is many different diseases. And even the same cancer diagnosis from the same organ is many different diseases. So the natural history for breast cancer is very heterogeneous, or for lung cancer, or for prostate cancer, or whatever. So we can't talk about one disease, cancer. We have to talk about it as many different diseases. And for some colorectal cancers, it's better to diagnose it sooner. However, in prostate cancer, breast cancer, lung cancer, melanoma, thoracic cancer, and kidney cancer, we know for sure that you can also diagnose it too early. So you can find it in a stage where it's not growing, or it's growing very slow, and you die from other reasons before you will ever get symptoms from this condition. So this idiom we have, the sooner the better, or a stitch in time saves 9, or whatever you say in English, is you can't use that in early diagnosis as a one size fits all. You have to be much more nuanced and balanced, and sometimes early diagnosis is much more harmful than beneficial.
Your work on cervical cancer and breast cancer, I think many of us kind of understand that a bit, but there's another, when you talk about melanoma, there's a huge push by our dermatology colleagues for early diagnosis of melanoma. Tell us a little bit more about that.
I'm actually doing quite a bit of research right now on overdiagnosis in melanoma, and we recently published a scoping review on overdiagnosis in melanoma. And from the studies we have found, we can see that between 1 in 3 and 2 in 3, 33 to 60% or 66% are overdiagnosed. And Paul Glasgow did a paper with some colleagues where he looked at Australia, and we are in the 40s and 50s of percentage of overdiagnosis in melanoma in Australia. So even in a country where you have a lot of white people with a lot of sun, you will have a substantial degree of overdiagnosis in melanoma. We also did a Cochrane review on screening for melanoma, and there's no evidence supporting screening. So we don't really have any high quality evidence supporting early diagnosis or screening of melanoma, but we have very much robust evidence of different kinds of qualities showing that it's very harmful to do early diagnosis of melanoma. So I think we have to rethink the whole issue around early diagnosis and cancer. And we actually just published a paper titled that, Rethinking Early Diagnosis of Cancer. This linear thinking where earlier is always better is a wrong thinking. We have to rethink it. We have to be much more critical to this part. Cancer can be a horrible disease that spreads very quickly and is very deadly. However, it can also be indolent and benign and never be anything of a disease.
It's interesting because you've published a lot, and indeed you've published a book as well. And in a sense, I've seen you described as Mr. Overdiagnosis. Do you get much pushback from colleagues?
Yes. Yes, but it's been more than two decades I've done research in overdiagnosis, and in a Danish context, it has been not easy 20 years. But 2 years ago, as you just said, I published a book, the first ever textbook on overdiagnosis. It's our target group is university students at medical and social science faculties. It's written across those two sciences, medical sciences and social sciences. However, it's been really perceived by health authorities, physicians, researchers, journalists, nurses, midwives, physiotherapists, all kinds of health professionals, really positive. And we have had a fantastic positive discussion around overdiagnosis in Denmark. And I can give you the glad news that we just signed a contract and are publishing now in English. And we have promised to give in the English manuscript in 2025. Hopefully, we will be able to do it before the year's over. But our book will now be published in English, and I'm worried and excited about it, because I'm worried that some people will be hostile around it and be aggressive and not accept it, because it's a scientific book. It's not a debate book. On the other hand, I'm really excited that we will start having a proper, sober discussion around overdiagnosis, which for me, except for the overuse and overtreatment, is the biggest problem we have in medicine. It's a global problem. We see it in all kinds of countries, and it is destroying our people. It's destroying our health systems, and it's actually worsening the climate changes because it increases the carbon footprint.
Those are pretty serious and important messages, and we really appreciate you've really asked a lot of hard questions. Let me ask you about something totally different. Change tack completely. So you're associated with the Arctic University in Tromsø.
Yeah.
Now that's a most unusual place. Talk to us a little bit about that.
I have some fun. I have been in my younger days, I have been working clinically as a GP in Norway, and the first position I had, the first locum I had, was for 4 months in the beautiful islands of Lofoten, which is just south of Tromsø. And then I had a good colleague working as a GP in Tromsø. And then after my 4 months, she invited me to come and have locums in her holidays. So I was there in Christmas, Easter, summer. It was during my PhD period. And then after that, I have done, as you can see in some of my publications, I've done a lot of research with my Scandinavian colleagues, including Norwegian colleagues. So I've always had a really good contact to Bergen and to Trondheim and to Tromsø. And then my good colleague, Lille Johansson, who is the leader of the research unit, she asked me and Alexander Jønsson if we wanted to be visiting professors there. So because they have lack of researchers in general practice, and my competence is in psychometrics and epidemiology, and Alex is an anthropologist, and she's very strong in social science. So I mean, and we are married privately, so it was a fantastic for us to have this opportunity to go together to Tromsø, where we are 4 weeks per year, and then it was I think a very good deal for Tromsø University to have this kind of couple coming with many years of experiences in this broad methodological competences. So
now we still have this very serious academic talking about psychometrics and overdiagnosis and epidemiology and all these really long words. But you have a most unusual and entertaining hobby. Let's finish off. Tell us a little bit about your hobby.
You mean I have 2 hobbies. One is very, I mean, that's very Irish or British. I mean, I play soccer. I play football, and I really enjoy it, playing with my old friends. And then I play brass band. And that's my wife. She forced me into to start playing cornet. It was the deal we made when we wrote the book, that when it was finished, I had to start exercising and playing cornet. So now I play in our local brass band, and I was actually participating. I don't know if you know this. The world's biggest brass band competition, with Friday, which is going on in the south of Manchester area, and I was actually there this May month in the Whitsundays, which is Friday after Whitsunday, and it was an amazing tour to see this culture around brass band music in that part of the world. I mean, it's such a big tradition in England and Scotland and Ireland and these countries. It's a very small thing in Denmark to play brass band.
John, it's been just fun chatting to you, and I'm delighted that we were able to get that final revelation that this very serious academic is a brass band cornet player. So we look forward to hearing about that in the future. John, thank you very much indeed. It's been an absolute pleasure. Thank you.
Thank you. Thank you. Thank you for inviting me.